Good morning, everyone. My name's Dr. Miriam Parsif, and if I haven't met you before, it's my pleasure to introduce Dr. Jenna Holmen, who was gracious enough to fill this slot slightly last minute because of reasons that I think are quite evident. So Dr. Holmen has joined our faculty, and we are just so joyful for that this year. She came to us from UCSF Oakland Children's. She has multiple publications. She is a wealth of resources. We hope to encourage her passion of antibiotic stewardship here at Cottage. So today she's going to give us an update on what's been happening in our community. Thanks, Jenna.
Thanks, Miriam. All right. So today I'm going to talk to you about the triple threat that's been hot in the news, COVID, RSV, and flu, a little bit of our local data, as well as just some general info on each of the viruses. I have a ton of slides, so I'll try to be very conscious of the time. So talking first about SARS-CoV-2. If for those that remember, I think it's been a huge epidemiology lesson to all of us, whether you were born epidemiologist or not, but the reproductive number of a virus essentially tells us how transmissible it is presently, the R effective. So when we look at California statewide on the left here, we can see that the R effective for COVID right now is above 1. And when it's above 1, that means the virus is spreading, like the infection rate is high. When it's below 1, it means it is not spreading, it's kind of contained, which thankfully actually in Santa Barbara County as of now, we are well below 1. There is a slight uptick, so I'm not sure if this will last throughout the holiday season, but so far we're doing pretty well in Santa Barbara. I did hear on the news on my way here, LA has been having a huge uptick, so I have a hunch you won't be too far behind. And this is data from Cottage looking at our COVID cases. So the blue line are actually negative tests. It's that green line below down here. These are positive tests. So this correlates with that low R effective we saw. There really haven't been a lot of COVID cases yet this season, but they are probably coming. And this is a graphic of the current COVID variants that are circulating. So BA.5 had been dominant for a long time, but really has been diminishing in recent weeks, being replaced by the variants we've heard about in the news, the BQ.1, BQ.1.1 especially. And we'll talk a little bit more about these and the vaccine in a little later. But the concern with these is that they are more resistant to the vaccines and therapeutics that we have currently. Touching on vaccines, this is where Santa Barbara County lies in terms of vaccine status. Close to 70% of people in the county have completed a primary series. That number drops off a little bit when we look at boosted, but it drops off dramatically when we look at those who receive the bivalent booster. The enthusiasm just hasn't been out there in the county. And I'll try to give you some evidence to help encourage patients to keep getting their bivalent booster because it really still has benefit. This is a snapshot from my email last week where I had to chuckle. We're a couple years into this pandemic and still there's so much conflicting data and things we don't know. So top story is saying that the current boosters, the bivalent, is likely not going to help with our winter surge. And then this bottom one here is saying that, oh, it actually might help. The middle one just saying that BQ.1 and 1.1 are now replacing the other variants, just increasing the fear about these boosters. So looking at what data we have for the bivalent booster, this graphic is looking at neutralizing antibody titers. This first graph here is looking at these against the ancestral strain, so the alpha strain. And we can see here that the bivalent booster, does provide benefit. Not that different from the original booster for the alpha strain. When we look at for the Omicron variant, we see that it does, have a notable benefit. But of course, Omicron is no longer in circulation as prevalent as these new variants. So there is some data out there looking at neutralizing antibody titers, especially with the BQ.1.1 variant. So these first two are looking at the monovalent booster, and you can see like there's some benefit still with BQ.1.1, but not much. But the bivalent booster, again, it's less protective against BQ.1.1 as compared to some of the other variants. But there's still, it's better than the monovalent, and there's still benefit. So it's still worth getting. Unfortunately, this is just looking at neutralizing antibody titers. It's not real world data because we just haven't had these new variants around long enough to test true, clinical disease and hospitalizations. This is yet another study looking at neutralizing antibody titers with the different variants with the bivalent booster. The green bars are the bivalent, and you can see over here is BQ.1.1, and you can see the bivalent booster really provides a significant amount of protection. This is pre and post. So still a benefit with the current circulating variants, not as much as with the prior, but it's still worth getting. All right, so moving on a little bit, just to give a little bit more fodder for common questions I've gotten from the community about trying to encourage families to vaccinate. I know there's been a lot of hesitancy to vaccinate that 6 month to 5 year age group. Parents just don't see a lot of reason to do it. This is some data looking at these kids specifically. This is just looking at cases. This doesn't include the current variants. This ends with Omicron. And this is just looking at COVID cases here, but what's most telling, so this 1 to 4 year group and the less than 1, they were actually a little bit lower with Omicron in terms of case counts as compared to older kids. But when we look at hospitalizations, this red line is 6 months to 4 years. They were the highest, and they sustained that. So they really were getting much more severe disease than the older children. And this held true among those who were hospitalized. The 6 month to 4 year age group, again, is still in red. And we can see they had higher rates of ICU admission, higher rates of high flow nasal cannula, smaller but slightly higher rates of need for BiPAP or mechanical ventilation. So all of this, is support for why it's still beneficial to vaccinate this age group. I know a lot of parents have been hesitant. I also want to touch on MISC a little bit. We really haven't seen much lately. I don't know if you've noticed, we really haven't seen much. And this is some data to show us why. So the blue lines are MISC cases, and this gray dotted line are COVID-19 cases. They have very different scales, so don't be fooled by the fact that MISC looks higher than COVID. It's not, it's just a different scale. But essentially what this is showing is that MISC is essentially disappearing with Omicron and subsequent variants. So we see here with Omicron, the COVID cases just soaring, and the MISC cases coming down and essentially turning into a flat line. If we look at the numerical numbers to support this, the risk ratio for MISC with Delta versus Alpha, 0.5. But the risk ratio for MISC with Omicron versus Alpha, 0.09. Like, it really is disappearing from existence. So that's good news for us as pediatricians. But if you still want to use this as an argument to encourage families to vaccinate, there's a lot of good data out there to suggest that vaccines are protective against MISC. Here we can see that for fully vaccinated kids, more than 14 days out from their second vaccine, the hazard ratio for MISC is 0.07, like highly protective with a good p-value. And then here's another study that's a case control study looking at the same thing. And again, you can see the odds ratio of MISC for vaccinated versus unvaccinated is significantly lower across all age groups and across different variants. Vaccines are also protective against long COVID, which I think might be the best argument that families might be receptive to, because everybody's terrified of long COVID. It's miserable. So this is just one of several studies sort of looking at this. The studies I've seen for long COVID break it down by symptom rather than presence or absence of long COVID. But you can see the adjusted risk ratio for various symptoms of long COVID for the fully vaccinated versus unvaccinated significantly shows vaccine benefit. And of course, vaccines are helpful for all the things we know that this pandemic has done to children. It's worsened their mental and emotional health. It's widened existing educational gaps, decreased physical activity, increased BMIs, decreased healthcare utilization. Routine immunizations have fallen way behind, and there's been an increase in adverse childhood experiences. So the more we vaccinate, the more we can move on with life and improve experiences for our children. So everything everybody here in this room, in this audience knows, just to call it out. This is one study I found particularly interesting that looked at not just the adverse experience on children, but the whole family, the household. So this was a survey of parents looking at the percent of parents who said that in the last year, they or another adult in their household had to leave or change a job or work schedule to take care of their children. And look how staggering these numbers are. I mean, 45 to 48% of parents either had to leave their job or change their schedule to take care of children during this pandemic. And this really brought home, the disparity issues of this pandemic, because those of Black race or Hispanic ethnicity were hit hardest by this, as well as those of lowest income. But I just find these numbers staggering and profound. And looking more a little bit at disparities with COVID and vaccines, we can see that really this bottom line here are those of Black race. They're the lowest vaccination rates, and that's been true really since the start of the pandemic. Interestingly, we look at the Hispanic race patients. They started off actually even a little bit lower than those of Black race, but they have actually picked up, and they've now surpassed the vaccination rate of white patients, which is 64%. Asian Americans are doing the best. And this is looking specifically at California. This here is data for children under 12 showing the disparities. We can see that Black and Hispanic children have significantly lower vaccination rates as compared to white children. And this holds true for older age groups for 12 to 17 as well. We can see 50 percentile versus 74. Right. Moving on to talk a little bit about RSV, which has been probably the leading virus in the news lately and in our hospital. So just a quick background on the virus of RSV. This is an enveloped, non-segmented, negative strand RNA virus. It has been reclassified maybe in the last 10 years to the Pneumoviridae family, which is the same family as metapneumovirus. So there is some overlap in terms of mechanism and symptoms, though RSV clearly is usually much more aggressive and much more prominent. There are two subgroups, RSV-A and B, and despite theories out there that this strain is particularly virulent, there really is no clear difference in severity between strains A and B, nor with this current strain per se. I think the severity is really just related to lack of immunity in our population. And the virus structure, the envelope itself contains 3 variable surface glycoproteins. There's these G proteins, and then there's also this F protein. And this will be relevant as I talk a little bit about RSV vaccines, which are very exciting, because the F protein is what's conserved across all the RSV strains. And so that's really the vaccine ideal target. Clinically, I think this is all review for everybody here, but 1 to 3%, which is a pretty high number of infected infants less than 12 months, will be hospitalized for severe disease. And this rate is the highest in those less than 6 months of age. The factors that significantly increase risk for hospitalization, of course, are prematurity, chronic lung disease, chronic heart disease, immunodeficiency, neuromuscular conditions, and variations specific for all of these, of course, are what qualifies certain patients for synovitis. Other factors that have been associated with a mild increase in risk for hospitalization include low birth weight, maternal smoking, family history of ATP, and lack of breastfeeding. And these are just some of the numbers of what RSV does to children globally. Children just less than 5. I mean, over 100,000 deaths a year in just this age group. 3.6 million hospitalizations a year and 33 million lower respiratory tract infections. Very huge. And RSV associated all-cause deaths up to 229,000. But it's not just kids that are affected by RSV, and this helps with research dollars. But adults over 65, they also can be hit really hard on levels almost comparable to flu. Flu in this age group causes about 21,000 deaths a year. RSV, well, about half that. But when we look at hospitalizations, it's about 3/4 the rate of flu, and outpatient visits, it's comparable. And these numbers don't really even take into account the fact that adults often don't get RSV testing. So I think it's really underreported in this population, though it is increasingly recognized, and I think the testing numbers are improving. So to look a little bit about what's going on in California this year, RSV detections from the Clinical Sentinel laboratories, so these are just tests. This graph I love because it shows RSV over the last 6 years, and this blue line here, this is this year. I mean, you can see how it's just a banner year, absolutely different from prior. And this yellow line here is last year. You can see we're well ahead of where we were last year. But the last 2 years, well, last year and the last 2 years have been interesting because RSV really started to increase in the summer, which we've never seen. Here's all the pre-pandemic years that followed the typical pattern we all know and so well as pediatricians. And then the first year of the pandemic, just a total flat line, hardly any RSV, and then totally off-season illness. This year, you can see this blue line is an extension here of the yellow. So it started early, but it really has just soared in terms of case counts. But it's not just cases. This is looking at RSV admissions in Northern California, which have also essentially tracked along with cases, just again, record levels, especially for this time of year. Sadly, deaths also are correlating with the prior graphs. So the percentage of RSV-coded deaths from this year are significantly higher than in previous years, especially for this time. And looking locally, this is the big surge that we had been seeing. Tentatively, there's hope. It looks like it's leveled off and even coming down. We'll see what the winter holds. RSV has traditionally peaked more in January, February. But like I said, everything's been totally changed in the last few years. So I can't promise that this lull will continue, but it's nice, at least right now, that things are coming down from their peak. But this is, I think, also an impressive graph. This is also our local data looking at RSV incidence over the last 2 years. And you can see in November and October, I think just those 2 months have outpaced all the RSV cases we saw last year. So this is really showing how dramatic this surge has been this fall. And no surprise when we look at the ages affected here locally, over half the cases have been children. So this sort of turquoise and I don't know what you call this color, pretty green, sea green. These are all the pediatric cases. And you can see that's definitely been the bulk of our RSV, probably maybe 3/4 of the cases, I'd say. And just quickly looking at RSV and disparities. So this is a graphic looking at the incidence of RSV associated hospitalizations by census tract poverty. And you can see this direct correlation that really skyrockets when we get to the highest levels of census tract poverty. So RSV, like so many illnesses, really hits those who are the most underserved. I want to talk a little bit about RSV vaccine because if you come to know me, you know how much I love vaccines. But RSV has been plaguing pediatrics for centuries, and there's finally hope of a vaccine out there. But a little bit of the vaccine history, some of you probably know this, but they actually started developing an RSV vaccine back in the 1960s. But unfortunately, this vaccine induced this severe reaction, which actually enhanced respiratory disease. And so 2 children sadly died as a result. So of course, this was completely stopped and nobody wanted to touch an RSV vaccine for kids for years. But finally, in the last 10 years, 5 years, there's been a lot of activity and things are finally moving forward. And one thing that has helped progress in this, going back to the RSV structure, I promised you I'd come back to this. What was really plaguing scientists is that the molecule of the RSV virus would change once it attaches to a cell. So here on the left, we see the pre-fusion RSV, and then on the right is the post-fusion RSV. And it's really the pre-fusion that they want to target with the vaccine. And but you can see like this beautiful target, this big red blob totally disappears once it fuses with a cell. And so it was really hard for scientists to isolate the pre-fusion form of RSV to develop a vaccine targeting. But finally, more recently, they've developed fancier lab techniques that have been able to crystallize this pre-fusion form of the virus, which has really propelled the vaccine research. So super exciting. And this here is a graphic of all the vaccines for RSV that are currently in development. So like I'm not kidding, there's a lot of progress on this. And here we're going to look at those that are specifically in phase 3, as well as a couple promising ones in phase 2. So here's just the phase 3 and ones. So oh, I should show you too. With the RSV vaccines, they have 3 different targets. So some of these vaccines are specifically targeting the pediatric population. Some are targeting pregnant women. And then a handful are also targeting adults over 65 or 60. So this is just a table of the vaccines in phase 3 plus 1 in phase 2 that are geared towards adults over 60. And this is still helpful for our kids because any herd immunity we can provide is really beneficial. But we'll talk about the pediatric or targeted vaccines as well. But I just want to draw your attention. Look at the efficacy of these vaccines. Like this is really good. 80%, 86%, 83%. And all 3 of these are in phase 3 trials. The one here that's in a phase 2 trial is Moderna mRNA vaccine. So we know from COVID, the mRNA vaccines work pretty well. So I have high hopes for this one as well. Pretty much all of these, they're planning to be annual vaccines like the flu vaccine. But I think it's really interesting to see this one, they looked at the durability for seasons 2 and 3, so further out than what's anticipated. And huge range, but the average was 76%, which is still actually pretty good. But I know we're all pediatricians, so we want to know about the pediatric vaccines. So these are those. And I will say this includes a couple monoclonal antibodies, and I'll tell you why I'm particularly actually excited about these. But first off, I'll say, so Pfizer has an RSV vaccine in phase 3 trials for pregnant women with 84% efficacy. So this will provide passive immunity to the child, the baby. So that's great. But why am I excited about another monoclonal antibody? We have Synagis. Synagis is okay. It's expensive. Its target audience is super limited. Well, this monoclonal here is, I'm told, though I don't know for sure, actually supposed to be much cheaper than Synagis. But the beauty of it, it's one shot, it lasts the whole season. So we don't need these monthly shots. And so both by being cheaper and less need for recurrence, it is open to a much wider population of babies. In fact, maybe even every newborn potentially. And we can see its efficacy is still really good, 70 to 74%. And this is in not only phase 3 trials, but it's been there for a while and is definitely known to do quite well. And even it's shown to have its durability extension into year 2, which is pretty cool. So this is some of the data on that particular antibody. So here we can see the hazard ratio for this monoclonal versus placebo, and this is super protective. And I should also say it's being tested both essentially in infants 35 weeks plus. So like I said, essentially late preterm and full-term babies, as well as the preterm group that doesn't usually qualify for Synagis. So, and it shows good efficacy in both demographics. So like I said, might be open to a much wider pediatric population, and hopefully, if what I've heard is true, not so unwieldy in terms of costs that would make it approachable. All right. So moving on to influenza, which has been the scourge for centuries. I love old pictures. So this is, I believe this is a graphic that was from the 1918 flu, but the way North Carolinians do at home. During the epidemic last fall and winter, 13,644 North Carolinians laid down their lives in a spit-borne disease, influenza. So influenza has a long storied history. It was likely the first described epidemic in 412 BC, described by Hippocrates and Livy. It was the first accepted epidemic in the 1100s in Europe, and it has been accounted for almost 300 epidemics up through 1875. The first known pandemic spread was from Africa to Europe. The second pandemic was in 1580 that started in Asia, then spread to Africa, Europe, and America. And this is just a list of some of the major influenza pandemics in the last couple centuries. These are some pictures from the 1918 pandemic. So the last time Americans did mask wearing. There was a lot of resistance to mask wearing even back then. But the 1918 flu, it killed more people in absolute numbers than any other disease outbreak in history, 50 to 100 million, which would be comparable toll today to 175 to 350 million. It was particularly challenging because the death rate was much higher in young, healthy people, which is not as typical with flu. And the death rate among pregnant women was 23 to 71%. It killed a third of the population of Alaska. And this was a particularly violent death. A lot of people had hemorrhage, bleeding from mucous membrane. And most of these deaths were actually due to the virus itself, not bacterial superinfections. So influenza can be quite scary. And some background epidemiology on influenza, just some global numbers. About 1 billion people get infected every year. This is pre-COVID data. Everything, of course, has been a little different the last couple of years. But it accounts for about 500,000 deaths in a normal year. In the US, there accounts for about 50 to 400,000 hospitalizations, depending on the year, 3,000 to 50,000 deaths, and 40 to 200 deaths in children. Children do have the highest incidence of infection, thankfully not in deaths, but the very elderly, the very young children, and those with comorbid illness do have the highest incidence of severity and death. So some basics on the influenza virus. This is in the Orthomyxoviridae family. It's a negative stranded enveloped RNA virus. There's 4 types. Flu A. Flu A is the only one that causes pandemics, and this is really because it's the only one that is prevalent in multiple different animal species. And the way a pandemic forms is when you get genetic transfer, between the human and then animal strain of influenza. The influenza B just has 2 subtypes, the Yamagata and the Victoria. And this can cause local outbreaks, but because it's only in humans and seals, evidently, which doesn't have a lot of influenza gene transfer, it really doesn't cause pandemics. Bet you never heard of influenza C or D because they don't really do much in people. C is generally asymptomatic and D apparently just infects cows. So this is just a graphic of the virus. So influenza is classified by its hemagglutinin proteins and the neuraminidase proteins. And what it does, it will invade the columnar ciliary epithelium. The hemagglutinin part, it will attach to the host cell, and then they has this M2 iron channel, which I don't see. Oh yeah, here. Which allows the viral transport into the host cell. And then the neuraminidase comes into play because it helps facilitate the release of newly produced variants from the host cell. All right, so, I was talking a little bit about the pandemic potential of influenza. And so just a couple epidemiologic principles and terms. So antigenic drift, this is what we can see year to year with flu. So you get a point mutation in either the hemagglutinin or the neuraminidase. It doesn't change the actual subtype. This can occur in flu A or flu B. And it can cause, potentially minor outbreaks, but it doesn't cause pandemics. It's antigenic shift where you get this major change in the hemagglutinin or the neuraminidase from recombination. It's usually cross species, and that's what has the pandemic potential. As I said, this can only occur in influenza A. In immunity to influenza, it's really a complex thing. It involves both humoral, secretory, and cell-mediated mechanisms. Subtype-specific antibodies will persist for years, but of course, these don't protect against future permutations of the virus. The antigenic shifts are what can render large populations vulnerable because nobody's seen that strain before. And then you have antibodies specific both to the hemagglutinin and the neuraminidase, and those for the hemagglutinin, those are necessary for virus neutralization, and the neuraminidase antibodies help reduce virus replication. And transmission, droplet spread, but also contact, as we know this from the hospital. But peak viral shedding really coincides with symptoms. The viral shedding usually starts about 1 day before symptoms. This shedding can last 2 weeks, so it usually ends 5 to 7 days after symptoms, with an incubation period ranging from 1 to 4 days. And I'm a graphic person, so this is in graphics. So the dark closed circles, that's viral shedding, and these white boxes are total symptoms. So you can see how they really line up. So symptoms really correlate with viral shedding, though viral shedding can precede symptoms by about a day early on. And you can see sort of peak symptoms, viral shedding around days 2 to 3 on average, but definitely can extend through days 4 and on. think we all know the various symptoms of flu, and these symptoms can vary by age. Infants, of course, are often more atypical, only have irritability and poor feeding or fever, but a lot of overlap with other respiratory viruses. Interestingly, the school-age children, they can have fever and respiratory symptoms, and GI symptoms tend to predominate in the preschoolers, whereas teenagers more likely have the fever, chills, headaches, the more typical symptoms we think of with adults. And it's the complications that we often fear so much with influenza. So the more concerning ones are the bacterial superinfections, which can include pneumonia in 8 to 15% of hospitalized children, most commonly secondary to pneumococcus and Staph aureus. You can also get bacterial complications of sinusitis and otitis. You can get acute myositis, which generally will occur during early convalescence. You start to get better, and then this happens. The calves are almost universally involved with this, and this is more associated with influenza B. I can't say I've ever actually seen that one. But influenza myocarditis is seen, febrile seizures, and less commonly, well, this slide didn't format well, are Ray's syndrome. I don't know what else I had on here. But you could, well, all right. Well, there's other less common ones too. I don't remember what I put on here. So looking more at our local epidemiology, we can see that our flu surge is higher than average. So this is the same sort of graphic we had for RSV, looking at different years, and this sort of bright blue is this year. So we're starting off higher than usual for this time this year. Not quite as dramatic as we saw with RSV. This is all cases, not just children, and these are just tests. Again, we can see that what the pandemic has done for our normal patterns, which are here. Here's pandemic year. This is last year, where the peak was really in June, which is so unusual for flu, and pretty flat during the winter, which is also so unusual for flu. Similar data, though a little bit more variable for influenza-like illness. So not everybody gets tested for flu. So sometimes we'll look at influenza-like illness as a cursory marker for flu and other respiratory viruses. So this also has a high uptick. And we look at our local incidence over the last 2 years, like we did with RSV. My goodness, like this year has been way higher so far than the last couple. Like we really didn't have a lot of flu last year, and definitely seeing a lot this year. And we look at the cases locally, they definitely still seem to be on the rise. There's a little bit of a promising downturn, but we'll see. It's not as promising as the RSV downturn. Really, flu has been rising, not hitting our children as hard. So this is a similar graphic to before, looking at the different age groups. So about half the cases in November were in pediatrics. These 3 colors here are adults, which seem to be about half. So definitely more diverse and spread out in terms of age groups. And just to talk a little bit about the treatment indications for influenza. Well, indications for treatment depend on the severity of the disease, the risk of that patient, and of course, the time from illness onset. The earlier you start treatment for influenza, the more effective it is. There's a couple different classes of medications, the adamantines, which really have widespread resistance. So we don't really use these very much, though amantadine is approved for children over than 1. What we more commonly use are the neuraminidase inhibitors. So oseltamivir, Tamiflu, that's of course our usual go-to. And this is licensed for treatment in children greater than 2 weeks, but prophylaxis only those greater than a year. Data suggests it may reduce illness duration by about a day if you start it very early. More perhaps importantly, it can decrease pulmonary complications in asthmatics. For severe kids that are admitted that can't tolerate orals, there is peramivir. It is actually technically licensed just for over 18, but studies do suggest it's safer in younger children. And it also will reduce the duration of illness, but so far the data hasn't shown that it decreases the duration of hospital stay. And there's also zanamivir, which is inhaled. And this is also licensed in children greater than 7. Can reduce the illness duration is started early as well. But just to look more at Tamiflu, because that's the one we've used the most. Is it really helpful? I found a lot of people have really strong feelings one way or the other. People love it, people hate it. Well, this is one study looking at the proportion of participants with symptoms who took Tamiflu and who didn't. You can see there's total overlap. It didn't do anything for these patients. And this is just sort of numerical data showing the same thing, except this is just looking at virologic measurements, not actually symptoms. And this is a Tamiflu group versus the placebo group. And essentially you can see these p-values are not great, like there really wasn't much benefit at all. So what's better than treatment? Prevention. Better not to get the disease at all, right? Especially when our treatment isn't great. So flu shot, really everybody should get it. Everybody 6 months of age and older, I should say. There are certain subgroups where it's even especially beneficial, like you really want to get them vaccinated, but everybody really should. And right now there's the 3 vaccine formulations. Inactivated vaccine. I'm told the live vaccine is still out there. Does anybody have it? Okay, wasn't sure. And then there's the recombinant protein vaccine. The recombinant vaccine is still not licensed for children as far as I know, but it's the only one that doesn't use egg-based technologies. So I'll talk about why that doesn't really matter that much. You know, I haven't heard this debate so much lately, I think because we haven't had the live vaccine available for a little while. But there used to be a lot of debate whether live versus inactive is one better than the other. And really it just varies by season. The live vaccine is the only one that induces mucosal immunity, which is a great thing to have. But really some years it's effective and some years it's not. So that's ultimately what it comes down to. The bummer is the vaccine rates do notably decline when the live vaccine is not available. Kids don't like shots. They'd rather have the squirt up their nose. So I had the live vaccine once. I didn't like it. I'd rather get a shot. And the egg allergies. You guys probably all know this, but yeah, really, they're nothing. People with a history of egg allergy of any severity should still get a flu vaccine, even those that are prepared in eggs. They no longer need to be observed for a long time after getting this. And severe allergic reactions in those with egg allergies are just extremely unlikely. So it shouldn't be a contraindication getting a vaccine. If they do have a problem with the vaccine, then that would be reason to be concerned for the following year. And of course, vaccinating pregnant women also helps protect the babies. So this is a study out of South Africa looking at HIV infected and uninfected mothers. So this essentially is looking at placebo versus vaccinated. On the right is the infants, the left is the moms, and we can see the rate of influenza was much lower in the infants whose moms received flu vaccine as compared to the placebo. This is the HIV uninfected, here's the HIV infected, similar data. All right, and looking at flu vaccine coverage in the US by age group, we can see that really, like so many of our routine vaccinations, the flu vaccine coverage has really dropped off with the pandemic. This last year here is 2020 to 2021, so I don't have this year's data, obviously. And we can see this here is a notable drop off when the live vaccine is not available. So it really does affect the vaccine uptake to some degree. And just touching on disparities again, when we look at flu vaccine coverage by racial and ethnic group in children, we can see the lowest rate again are Black patients, and followed by the Hispanic patients. And the Hispanic patients really notably crossed lines. They were doing, they actually had the highest vaccine rate in 2018 and now fell down to the second lowest. And we look at influenza disparities for hospitalization. So our Black patients only have the lowest vaccination rates, but they also have the highest rate of hospitalization. Hospitalization rates compared to white, and this is just adults though, but 80% higher in Black adults as compared to white adults, 30% higher in American Indians and Alaskan Native adults, and 20% higher among Hispanic adults. So really, these disparities in vaccinations and illness really persist across all infections. But sadly, as much as I love vaccines and I love our flu vaccine too, it's not perfect. Nothing in life is, right? And so there is waning in efficacy of the vaccine with time. So here we can see days since vaccination right along this column. And then this is test positive outcome of having flu, and we can see it just steadily increases with time. Not surprising, we see the same thing with COVID and boosters. It just the durability of these vaccines isn't great, which is why we get them every year. We try to time it in the season so you have protection during the season. But unfortunately, if you look at these like day numbers, it doesn't even really protect for the whole season always. And here it is looking specifically at kids. Same thing, we still see this waning over time, maybe not quite as high as in the adults, but definitely the case positive ratio of flu over time after vaccination does increase. All right, this is ID week, the giant flu monster before COVID, so we're not wearing masks. Any questions? I think I saw some red dots in the chat somewhere.
But do you have any thoughts about like it should be 5 days for flu or for isolation periods and RSV as well to send kids back to daycare, things like that?
Sure. If anyone didn't hear the first part of her question, it was just about timing for returning to school after flu, RSV kind of infections and daycare. And I think if you want a straight cutoff, the 5 day is a reasonable rule of thumb that's nice and safe. But I think if you want to make it more patient-centered, certainly if you go by symptoms, that would be probably the most correct and correlate the best. But most kids, per the data, the graphs and clinical experience, by 5 days, they're usually better. So I think that's sort of where that cutoff came from with COVID, plus the testing data. But certainly can make it more patient-centered for those that recover sooner. It's probably okay to go back a little sooner.
Go ahead, Dr. Brennan.
Hi, are you able to hear me?
Yeah. Yes.
Great. First of all, thank you for this awesome talk. Probably the best ground rounds I've had that I've been part of in the 20 years I'm here. So welcome to the community and thank you so much for the talk. My question was about RSV, and in talking to some friends who are pediatric hospitalists at some of the major children's hospitals, what I keep hearing from them is that, especially with their younger patients, they're needing subjectively more respiratory support than they've needed in previous years. And they've had objective values like much higher CRP values to go along with that. And so I just wondered if we were seeing that trend at Cottage. And then I also wondered if when we're looking at the sort of vaccine or the immunity gap theory for for why we're seeing more RSV, how that would really correlate with a 6-month-old who really wouldn't have been exposed, in the first 6 months any different than in previous RSV seasons. So it would seem to me that the disease would be the same in that younger group and wouldn't be acting differently. So just wondered your thoughts on that, and if we're seeing anything like that locally, or if you've heard anything differently from your colleagues.
Yeah, thank you for that. Thank you for your kind comments and your great question. But yes, at Cottage, we have been seeing, it's my first year here at Cottage, but I can say the RSV that I've been seeing here has been more severe than I'm used to seeing when I was up at UCSF. So I think it's been more severe than is typical for Cottage this year. So it has been consistent, I think, with the national and state trends of the data I showed of being more severe. In terms of the immunity question, yes, it's still open for debate, but I think part of it, these young infants, although they never had immunity, they probably had previous to this year more protection from maternal passive antibodies. So like their moms haven't seen RSV in a few years, so probably have lower levels of circulating antibodies that they're passing to these babies. So I think that would further decrease their protection and lead to even more severe disease than we've traditionally seen. So because RSV has been around for so long, and really we just don't see that, one strain has ever been more severe than another. I think that to me is a more likely explanation, is just this lack of maternal protection, lack of protection from prior infection in older kids. Certainly we are seeing more older kids get infected than historically we've seen.
Awesome. Thank you. That's really helpful.
Yeah, thanks.
I get a lot of concerns about what the side effects of flu vaccine are, because most of my patients, when I counsel them to get it, they say I get the flu from flu vaccine, or I've had a bad reaction to it in the past. So I was wondering if there's a way to counsel patients and kind of let them know what to expect for side effects of flu vaccine.
Yeah, it's such a great question. The stock answer that I'm trained to give, which I don't think convinces many people, is that, you're probably already infected with flu. You're going to get it anyway. It's just the random luck of the draw that you got the vaccine right before you got sick. Really, the studies do not show that the vaccine causes flu or makes you sick. Some people might have very mild symptoms for a day or two after the vaccine, but shouldn't have anything major. And I think the most important argument to emphasize is that even if you have sort of mild fatigue after the vaccine, it's so much better than the actual flu. Like getting flu is so miserable. Even if you're not hospitalized or have severe disease, it really, you're out of work, your kids are out of school. It can be a big impact, but it's a hard thing to convince families, I know.
Hi, James Brewer, a community pediatrician. I've been giving the Pfizer flu or COVID shots for a couple of years now, and there is some resistance to giving those shots to young children when they don't seem to have a severe illness. But what I've thought about was there seems to be quite a bit of logistical problems with getting the shots out into the community. And I'm wondering if you know anything about changes for the future on how those vaccinations are distributed to the community, and whether or not there will be, for example, packaging them in individual doses as we transition to giving it as a routine immunization as the pandemic starts to change into more of a long-term issue.
Yeah, that's such a great question. I don't know anything about that. I haven't heard anything. I would dearly hope they're looking into it, but I don't know.
It also seems like we need to really simplify the administration, because There are so many different formulations, which is understandable because to this point, since it was put out as an emergency use, there wasn't a lot of time to research dosing and whatnot. So I think there was a tendency to give, lower doses. And as we saw with the flu shot years ago, when babies were given, half a dose, and then after a while, they decided to simplify it and just kind of give one flu shot for everybody. And I think that really increased the uptake. So by making some changes for the future, I think there's a possibility of getting more people immunized,
Yeah,
which could really put a dent in this pandemic.
yeah, I think that's a great point. I mean, at least they're aware of that factor. They tried to simplify things a little bit when they brought out the bivalent booster. Instead of needing X number of boosters, it's just one bivalent done. But in terms of dosage, you're spot on. And to add to that, the Pfizer vaccine for kids in that 6 month to 5 year age group, originally it went for FDA approval and they rejected it for the EUA, and then so it went back to studies. And really, the dose they picked was too low. It wasn't causing enough protection in kids. And rather than reevaluate it at a higher dose, because that was going to delay their approval, they just gave an extra shot. So that's why it just added to the complexity that this age group now needs a bonus shot if you're giving them Pfizer, because they didn't take the time to do the right dosage study. And yes, with the third dose, they do get decent levels of protection. But I think a higher dose in that age group would not only give the protection they need, but still be safe and would simplify things. Absolutely.
Good morning. This is Dr. Castañeda. I am a senior pediatrician in town. And for years, I used the flu vaccine without any major problems. It's very, very safe for my kids. I have one of the busiest practice in town. Thank you.
I wonder why would RSV vaccine need a yearly booster if it doesn't seem to change, if they're not going to be adjusting it based on?
Yeah, it's not so much that the question was why RSV would need a yearly booster if the strain doesn't change the way the flu does. I think it's not so much about the strain changing, it's just the durability of the vaccine. Like it just doesn't provide long-term protection, kind of like the COVID vaccine. So COVID changes.
Has there been any discussion about 2 series flu vaccines? Because when you look at that data in terms of the days of kind of effective immunity, and I mean, I know we're not able to predict the length of our flu season anymore, or predict anything anymore. But has that been discussed?
I've heard it discussed actually pre-pandemic in the older adult group, like that highest risk group, where I think even maybe some providers have given their highest risk patients a second dose sort of in January, February to take them up through the rest. But it's never been incorporated into the ACIP recommendations, though so much data would support that, I think, definitely. And you're right. And when our seasons are so unpredictable and we're seeing rises in the summer, your flu vaccine in September, October is not going to provide you much protection at all the following summer.
I want to respect everyone's time, but thank you for presenting really complicated data real time in such a clear and concise manner. We're really lucky to have you. Thank you, Dr. Holmen.
Thank you so much.